two TADS in a row, and we run the T-wire through both TADS. And we'll look at that case from start to finish in just a little bit, so you understand how powerful this T-wire is, and again, how inexpensive it is. See, that's the beauty of it. You can have a lab make all sorts of complicated, expensive appliances. I love the benefit system, for example, Benedict Vilmas's system that is made by PSM. But you know what? It's sinfully expensive. You cannot load the TADs the day you place them because you need a lab step, because you always need to make a lab appliance. And you can do all these things with the TAD with the cross slot and the right auxiliaries and a little bit of smart thinking. That's what the T-wire looks like. You adapt it, you bond it in, and you protract. So, I get to show you some cases. You have a few ideas of how I use TADS. Obviously, this is just a little bit of a cutout out of a 6-hour presentation, so there's a lot more indications. But if you get the concepts, you can design your own biomechanics, because there is no right and no wrong when it comes to biomechanics. When it comes to insertions, what we did this morning, there's very clearly a wrong way to do it and a right way to do it. But when it comes to biomechanics, once your screw is stable, there's a lot of different ways to move teeth with the stable screw. And you can do whatever you feel like doing. And if you haven't used TADS yet, don't wait. Don't wait for that one terrible case where you think, oh my God, how am I going to do this? Let me put a screw in. You can use TADS every day on all of your patients to make your life easier or the patient's life a lot easier. So I'm going to start out with the really simple case, okay? This kid right here moved to Cleveland. His orthodontist had put on the braces. He had a blocked arcuspid class 2 on the right side, and the idea was to extract the upper right 4, finishing a class 2 molar and a class 1 canine on the right side. Very appropriate. Well, when he came to see me, I said, obviously we can continue with that treatment plan, or we can also save you the extraction and put in a TAD. Well, the parents said the TAD sounds a lot less painful, and so they chose the TAD. And how do we solve this issue? Well, so you just put a TAD in, and you bond it to the lateral. And now you lock in the lateral. This setup costs you whatever it costs to put in a TAD, and maybe 2 cents for a little bit of stainless steel wire, and a little bit of composite. All things you have lying around in your office. And now you put a push coil on here. And we're going to start pushing. And we're going to start opening up the space. And once we're class 1 and we have space for the canine, it's time to take out our base arch. And now we can put in a 14 night tie, run it up to the canine, and bring it down. But what's my concern when I take out the coil spring, when I take out the base arch? Well, I'm concerned that before I bring the canine down, things will come forward again, right? I'll lose anchorage. And this is the nice thing about Thomas. It is actually made to be used with composite ligation. So that's how we attach the wire to the head. The wire sits in there, we put a drop of composite on it, it flows into that undercut I showed you guys, and it locks in the wire. If you now want to change it, all you do is you take a Weingart and you crimp the head, and the composite pops off. It re-exposes the head, like so. And now we can use the same screw, same spot, we're not moving anything, and you put a different wire in there, and you can now hold your molars back while you're running your 9-tie wire up there to bring the canine down. Now we do a little bit of detailing and finishing, and we finish up with a nice result, class 1 on both sides, and a happy patient where we've avoided extractions. Minimal cost, maximum effectiveness, you've avoided extractions, and it creates happy patients, and it's kind of a cool thing to do. Missing lower 6, collapsed ridge. So this patient had a long time missing first molar, and you can see she's African American, she's bimax protrusive. I had offered her to extract the other first molars and retract to reduce her protrusiveness. She said, that's my ethnicity. I like that. On a side note, we have a lot of African American patients in Cleveland, and a lot of them consider the midline diastema as an ethnic trait. and they want us to straighten teeth, do everything, but leave the midline diastema. So she wanted to keep her protrusiveness, and she just wanted that space closed by orthodontic means, not by prosthodontic means. And she understood that this third molar would have to be extracted eventually because it doesn't have an antagonist once we finish the protraction. I'm showing you this case because it's such a beautiful example of how you properly protract. So this is Layla on the day that she's getting the TAD. We're in our leveling, we're done with the leveling and alignment. We're in our working wires where I like to slide, 1725 stainless on the lower. And we're going to focus on the zone of opportunity down here, obviously, going between 4 and 5. So when we look at the buckle, you now fully understand why that implant is where it's at, okay? And now we insert the crimpable connector the way I showed you earlier. We crimp it distal to the 5, and we run it down into the screw and fixate it there with composite. And now we do a power chain. And I'm running a sling from the 6 around the post back to the 6. And later I'll run a sling from the 6 around the post back to the 7 and start protracting both. But I'm just getting it going a little bit. And so here you can kind of see a close-up view of the crest. I'm showing you this case because people always ask, can you protract molar through a collapsed ridge, a knife-sharp, saddle-shaped crest? And yes, you absolutely can. And if you look closely, here's the TAD, again, right below the dental contact point because the roots are divergent. I keep repeating myself until you're sick of it, but when you go home tonight, you go to bed, I want you to dream of this. Roots divergent, TAD below the dental contact point, off the midline in the palate, 2 millimeters, measurement level 2. That's the mantra, bum, 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 all the time. You do the same thing over and over and over again, you get really good at it, okay? So, right below the dental contact point, you will not have roots because they're divergent. And look at that crest, it's really saddle-shaped, collapsed. So, it only took us roughly about 6 months, and that is a rare example of tooth movement, especially in an African American with the collapsed ridge. That is rare. Normally, you would expect about a year's worth of treatment. She responded really well. But, fact of the matter is, you can see very nicely how this crest is resolving. So we have some lingual attachments here too now. And as the 6 is coming forward, I'm now running the power chain from the 6 to the post to the 7. You can probably see that here. I'm just bringing these teeth forward. And then we're finishing her up with a decent result in the end. And nothing's changed here. But we brought those molars those molars forward quite nicely. She ended up keeping her third molar. She asked us to include it in the retainer, which we did. And I've seen her 2 years after the retention, but this case is about 10 years old, so I haven't seen her anymore. I'm assuming no news is good news. I'm assuming she's happy. This is a really cool case. I showed this case in 2013 at the AO, and I called the lecture Orthodontic Alchemy. And this is really, I'm not converting lead to gold here, but it certainly is almost magic, okay? Because if you look at a case like this, 17-year-old girl, a bombed out molar, and a missing first bicuspid, general dentist planned a root canal and a crown, and they planned a dental implant here. Luckily, her friend was in treatment with me, and they just trusted me, and they came to see me just to see what my perspective is on things. They didn't even necessarily want braces, but they wanted to hear what the options are. So we talked about another option. What the general dentist planned wasn't wrong, but another option is to take out this tooth and do protraction because she had unerupted third molars. And that's what she went for, okay? And you can see a TAD right here, and you can see a TAD, you cannot see the TAD, but it's right here. And again, fresh extraction site. And you can see how those third molars are sitting up there just wanting to be used. To me, third molars are like spare tires on a car, okay? Don't just take them out. Sometimes they come in really useful. And so Now we're putting in the TADS and we're starting the protraction. And another way to do this would certainly be with the T-wire. That was my initial plan. She was African American, so her cortical bone was a little thicker in the palate than my studies indicate. So I noticed when I tried to do the palatal insertion that things were really, really tight and there was a lot of resistance. So I could have pre-drilled, but I didn't want to. I understand cortical bone thickness. I know it's thinner on the palate, on the buccal than it is in the anterior palate. And so I said, well, if the palate is like this, then the buccal has to be perfect. So that's why instead of putting in the palatal TADS, I ended up doing 2 buccal TADS. And you've seen Layla's case previously with the crimpable connector. Here we did it on both sides. Crimpable connector. You can see there's no overjet. So any anchorage loss in the maxilla would be a problem. And on one side we did the power chain sling that I described before. On the other side, because I'm just moving a single tooth, I did a coil spring. And this is her, dazed and confused, but happy, after we put in 2 screws. And you can see the power chain sling here, you can see the crimpable connector. It doesn't affect her smile at all. She's a good looking young lady, nice smile. And once we're done with her,